Hi, my name is Sean. I'm a ICU nurse at Conway. I've decided to do my IPP project on finding a bundle or algorithm to expedite the ventilation time that our patients spend on mechanical ventilation. I tried to actually find information regarding certain types of patients to develop an algorithm for each type of patient, but essentially what I found out was you need to fix the whole reason why they're on the ventilator to get them off the ventilator itself, to even begin to wean them. So once you do that, it becomes a streamlined process, essentially. Using a tool called the Burns Wean Assessment Program Checklist, what you find is that it's a tool that is essentially the gold standard. You go through here and you find information of yes and no's on if the patient is essentially ready to be weaned. This information is really important. This whole project is really important to me and our unit just because the average estimated ventilation time is approximately 3 days. Our average ventilation time is almost double that. It's almost 6 days. I believe it's 5.8 days. And that's just for the average patient. We have several patients that go up to 12 days, and many patients actually, about a third of them actually get re-intubated. So I'm going to discuss of what tools that we can use, such as the Burns Wean Assessment Program Checklist, along with the ABCDE bundle. If we kind of bring those together and collaborate more, I believe that we can actually get our patients off the ventilator much more quickly and decrease mortality and get them out of the hospital faster. Essentially, what we have is just one pulmonologist, and we're not really involved so much in Conway with the weaning of the vent. The only thing that we can change or really have an impact on is the percentage of oxygen that they're on, which is fine. But we really have no way of looking at a big picture, having a tool to use to say, okay, they are ready to wean, I need to call the doctor up, or anything like that. As far as as far as using the other tool I was discussing, the ABCDE bundle, that bundle consists of very few things. It involves essentially just looking at the patient, assessing them, and doing awakening and breathing trials. You do those synergistically, you do those together. We do spontaneous breathing trials, but rarely do we do waking trials because mainly we use Versed. Has a longer half-life, takes forever for it to wear off, and once they're awake, we've got an older population, so that they could be slightly delirious or in some kind of delirium due to the fact of that. So my take is that if we were to implement a shorter acting sedation medication, then we could do more effective waking trials. And we would be able to assess them for delirium and treat them for that as needed, which is part of this whole bundle. And as I said, we don't have an official bundle that we follow at Conway. So I think that this is really important as far as that goes. There's a lot of collaboration with this. The RN, the RT, the physician, we all collaborate. We discuss the goals of the therapy, where we're at, seeing where they stand on any delirium that they could get from either the whole reason why they're there at the hospital or the medication sedation that we're giving them, which can easily extend the time that they spend on the vent. There's also, let's see, There's also other things that we can address, such as making sure that we do range of movement, and addressing that as it goes along, because the faster that we get them moving along up and doing some sort of exercises, maybe not while they're on the vent, but after ventilation or extubation, then the less likely that they are to probably end up back on the vent. Another thing that I found out is that anyone who's been ventilated for more than 3 days, it actually shows promise that we, instead of placing them on a venti mask or nasal cannula, to actually place them on a BiPAP, non-invasive ventilation for 24 hours just for monitoring. That has been proven to actually improve the chance of re-intubation. Something else that's a misconception is that only extubating in the morning times. There's a study that was performed that shows that that is false. A nighttime extubation is just as successful as a daytime extubation. So there's 12 to 16 hours right there that you could take away from them spending time on the vent, where they could end up developing pneumonia or some other issues, pneumothorax, anything like that. So those are some things that I found very interesting. I have discussed this with my clinical coordinator. I've mentioned it to her. She's looking into it. She is a new hire. She was just hired a few days ago, so I brought this up. I've also discussed the burns checklist with the respiratory therapists. We're trying to get something implemented into where we can have a bundle where we are all on the same page, where, us, the patient, the RTs, the physician, we are all on the same page, and we are all able to collaborate in order to get this patient off the ventilator as fast as possible.